I will now invite Jhimly Baruah, who is working as a public health planning consultant with the National Health Systems Resource Center and provides technical support to state governments towards strengthening the health systems. She has over a decade's experience of working with national and international development organizations. Her areas of expertise are program management, decentralized planning, and research studies. Over to Jhimly.
Everyone, we had a very interesting presentation from Upendra on the urban areas and its issues. So from the urban areas, we come back to the issues of the rural areas again, and particularly, and again in the context of the National, Rural Health Mission. My presentation basically deals with the challenge of availability of human health resources, and which is basically one of the critical areas in the public health system. The problem here is the availability and the distribution of skilled healthcare providers, which is skewed, as we know, and hence the challenge of how to get health providers to work in the rural and remote areas. This is not a new problem. It's quite an age-old issue, and the causes are quite well known, and we also know that there are solutions to this problem. But in order to address this problem, one needs to really understand and determine what is difficult and what is the difficult area that we keep on discussing. Internationally, a lot has been done in this area in trying to get basically skilled health providers to the rural areas, and all of these have changed the perception in the last decade that this problem is remedial, and the problem can be closed. Some of the notable steps which have been taken internationally in this direction are the WHO resolutions on migrations in 2004, the Kampala Declaration and Agenda for Global Action, the G8 Summit, and the Global Health Workforce Alliance's report in this regard. Some of the key research and policy questions which emerges from these deliberations, these discussions, and these reports are: what is the role of different factors that influence the choice of locations of health providers? What are some of the effective retention strategies which ought to be designed and implemented in order to improve staffing of rural health facilities? What are the prerequisites for design and implementation of these strategies? How effective have these strategies been in influencing health workers' location? And how can the effect of retention strategies be measured and evaluated? Our study basically deals with the first two questions. We understand, and particularly from various health system studies, that the access to health workers in remote and rural areas depends on two interrelated aspects. That is, the factors which influence decisions, choices of locations. Why do people go to live in or stay in rural areas? And finally, what is the health system's response in trying to get health workers in rural areas? We also understand that health workers basically stay in rural and remote areas due to the opportunity cost. Wherever the opportunity cost basically outweighs the benefits of being in the rural area, they would go. Similarly, the human behavior also influences their rationale or the reason for being in a rural area. The challenge here is not of getting health workers in the rural areas, but of getting the right skill mix and the right talent and the right attitude and in the right person and in the right place. There have been several interventions which have been tried to increase access of health workers in underserved areas or difficult areas. And these can be broadly categorized into these four categories: educational interventions, regulatory interventions, monetary compensation, management, environment, and social support. The details are in the, I think maybe the print would be probably too fine. I mean, it's too detailed, so I'll not read them out. But we are quite, all of us are probably quite familiar with all of these. Particularly the third one, which have been tried to a large extent by most countries, and particularly India. Now, what's the Indian scenario? like elsewhere in the world, we also faced with the same crisis of scarce human resources in our rural areas, particularly with 26% doctors. And we know the reasons why they refuse to come to these areas to work. And hence, in India also, in the last decade or so, several states have tried several interventions to address this problem. And like in the earlier slide we have said, they can be classified to regulatory measures, which are basically bonds for mandatory rural service and compulsory rotation of postings, which have been tried by states like Karnataka and Tamil Nadu, and also states like Assam, Meghalaya, Chhattisgarh, Kerala. Educational measures, which basically include developing cadre of health workers, developing health workers and training them in special courses, which have been tried by Assam, West Bengal, Chhattisgarh. There have also been measures which address workforce environment, such as rotational postings, fair and transparent postings, tried by states like Karnataka and Tamil Nadu. And last, financial and non-financial incentives. This has been tried by most states across the country, like Himachal, Jammu Kashmir, Chhattisgarh, and most of the northeast states. The advent of the National Rural Health Mission provided the opportunity to look at the problem of scarce human health resources in the rural areas and find new and innovative solutions to this age-old problem. And hence, there was a felt need, having learned from the states who have implemented this kind of measures, how to get something like this working at the central level and across states. And at the center, it was basically being decided or basically being thought that the central package would be required of a financial, non-financial incentives for doctors and paramedical staff to work in remote areas. But prior to this package to be determined, the center also tried to look at the states and what they have been up to, what they have worked on so far. And it was seen that most states have devised or worked on difficult areas and categorized them. Sorry. So for a central package, and then from that it was decided that for a central package, there would have to be a standardization to be done to define what is difficult, so that to be fair to all the states. And now the process, at the behest of the MOHFW, NHSRC was asked to determine criteria for determining what is a difficult health facility, and based on this, how to develop a package of incentives. But the challenge for this was that the criteria had to be robust and objective so that it could be consistently and rigorously applied across all states and it would be fair to all of them. While evolving the criteria, we looked at difficulty in terms of 4 dimensions. One was physical accessibility or geographical accessibility. One was the environment, the social and physical, the housing availability for the service providers, and the extent of success in filling the vacancies of providers in the past. Once the criteria was decided, each of the criteria was scored and weightage was given to the remoteness and in all those 4 criteria. But the maximum weightage was given to the difficulty of the physical accessibility. And each facility was then scored in terms of physical accessibility, which is an A score, environment, which is an E score, housing and family amenities, which is an A score, and vacancy situation, which is a B score. All of these were combined into a composite score, turning into an AEHV, where the most difficult facility would be expressed in terms of A5, E5, H3, and the least one being A1, EO, HO. This mammoth exercise across the states was done by NHSRC with the collaboration with several other agencies, including 10 professional research agencies. And the entire data was scored in-house and categorized. And lists were prepared for each of the states. This resulted in an extensive database of over 26,000 health facilities across 620 districts, and facilities above the subcenter and below the district hospital were measured. Once these lists were prepared, they were compared with the state's list, and this whole perception was matched. In over 90% cases, the objective criteria matched the state's perceptions, and only in 10% there was no resolution. This is a glimpse of the database which for EAG states. And in most places we can see that there's a wide range in terms of the difficulty measured in terms of what was done by the states and what was done by and HSRC post the review. Now the discussion here would be that, this baseline of difficult facilities provided the states the flexibility to modify their objective basis. It also helped them to alter the difficulty threshold while retaining the basic baseline method. And we found that this approach was used by a couple of states with good results. But we also felt the center had to prioritize more for some of the difficult and hilly states, and even for the better states, so that it was fair to them. This database can be a good starting point to be used for designing strategies for attracting and retaining HR workforce in difficult areas. It could also be used for designing differential strategies for incentivizing as per gradient of difficulty. But this is a problem which we are just beginning to understand yet. And there's more rigorous study, more research that needs to be done in this area to understand this problem further and to turn it into policy initiatives. Thank you for your attention.
Thank you, Jhimly. If you have questions, please pass them on to our volunteer. And if you could then pass it